Hi folks, Professor Finn here. Let's look at Chapter 19, Delayed Embalming. So the broad rule, and this is pretty much beaten into us as soon as we start working part-time at the funeral gig, right, is that the sooner we get the body, the better job of embalming we're going to actually do for it. Unfortunately, in today's day and age, delays are becoming more and more evident. Us being a transient society, people are out of town waiting on okays and notification of who to deliver to. So it's not uncommon that a body can actually sit in the morgue for several days before the funeral home even knows a person has died. We've seen that when a person passes away, that changes begin to happen. They might not happen simultaneously, but there are definite changes that happen. And there are three common problems with the delays. The first is that we're going to have distribution and diffusion issues. The body just simply is not going to embalm as good for a ton of different reasons, which we've studied extensively throughout all of the chapters. Swelling's going to happen, especially in the face, okay? And we're just going to need more fluid to do the job. So even with refrigeration, decomp is only slowed down. Decomposition is not stopped completely. Preservative absorption is usually greatest immediately after injection. Most bodies exhibit some degree of firming. So the body immediately after injection is actually going to firm, somewhat, no questions asked. The concentration of formaldehyde at that point, or formalin, is at its highest point. But over time, it's going to end up diffusing, going further different areas, and preserving more of the tissue. So if you've done your job right, even if you don't have them quote-unquote bricked, rock hard, after several hours you are going to see complete firming, or even up to a day later, depending on a lot of factors. A lot of it has to do with the type of fluid using, the conditions of the body being the second one. When we deal with anything with delayed embalming, for instance, what we're looking at is a minimum amount of stronger solution. Trying to do the most good with the least amount of fluid pushing in. So we have some things that can help us. Manual aids. And here are an example of manual aids. This is extremely important. Note card this, write it down, whatever it takes. We have mechanical aids. Okay? Typically requires an instrument, and it gives you some options. And then operative aids. As soon as you see the word operative, it almost always refers to cutting. So you need a scalpel or a trocar or a hypodermic needle. So we have channeling, incising, and excising. So the general protocol is a recap of Chapter 1, the 4 steps of the embalming analysis. And for under-embalmed areas, you have 3 choices, ultimately. Sectional embalming, surface embalming, hypodermic embalming. Parting it out, doing the arms, the legs, everything separate, attacking the surface only, okay, the surface only, which would be cavity compresses, etc. And finally, hypodermic embalming, which is breaking out the needles, the little bitty ones, and the syringes, and injecting a phenol or cavity fluid. Restricted cervical injection or 6-point, multi-point is strongly suggested for bodies with delays. 1-point injection is not recommended due to lack of control of the fluid entering the head. So we want to be able to ensure that we have enough into the head to get the job done, and we don't get that with 1 point. I'm not going to go into great depth with the injection styles that are available. Nothing should be new or surprising. But when there is a long delay between death and embalming, you should inject very slowly. Now, I am operating, I've primarily worked on 2 machines my entire time. I've worked on the Duotronics, and that is specifically Duotronics that have both control over rate of flow and control over pressure, not an auto sensor. And I've worked on the Dodge machines, which I've worked on both of those, the ones that have manual rate of flow and pressure, as well as the automatic sensor. So for a Dodge machine with an automatic sensor, for instance, I am probably going to inject, if I'm going to use this theory, is I'm probably going to be injecting initially at less than 10 on a pulse. So if I'm hitting that 10 mark, I'm probably pushing my limit. And again, there is subject to a lot of different preference out there, and I can do different injection styles with different types of machines. But generally, I have done very good had very good results by starting at 10 or under on the automatic pressure sensing machines, and then building up later. Book recommends pulsation, and I do as well. That is something I do in all the bodies here in Miami. And I will tell you that if I get a body, that I think the earliest time I've had for remains has been 3 days, where a person passed away in 1 day, and 3 days later I got it. And the most I've had is about 32 days, where they passed away a month and then some prior. And utilizing this technique of very slow injection and building up later, I've had an excellent and pulsation is almost a gimme with it. So to get pulsation is, number one, pay for it, okay? So you actually bought it with the machine when it got there. And if you did not buy that added-on feature, you can manually just turn the rate of flow valve on and off. So turn the machine on, then just grab rate of flow and open and close it, kind of like if you were doing an instant tissue fixation or a head freeze or something like that. You can bend the hose. Okay, you can bend the hose. Give it a good thing so it actually stops the flow. Starting and stopping the flow of fluid with the rate of flow valve, so a little stop cock, for instance, okay? You could do that, and turn the machine on and off. I do not recommend that you turn the machine on and off. That can really mess up your pump. I also don't like playing with the rate of flow valve, because of the fact that, especially if you're using something like a slip, arterial tube with a slip connection, it can pop the hose off. And again, there are things you can do to prevent that. But I don't like articulating the knobs that often, because I think that puts undue wear and tear. So realistically, buy yourself a stopcock, or just buy the machine with it. And I can't imagine too many machines come without a pulse feature anymore. Rigor would be probably one of the most common things that you encounter. And in some bodies, it makes it completely impossible to actually do anything with the body. It's just completely shot. This is most evident in people that have a very well-formed musculature. Emaciated or extremely malnourished, cachexiated bodies do not generally form very intense rigor because the muscles aren't in that good of a condition. And all bodies will encounter some type of rigor and can be relieved through whatever normal means. Rigor mortis affects all muscles immediately. Any activity that reduces the energy for the muscles, adenosine triphosphate, ATP, prior to death, is going to speed the onset of rigor. It can occur instantaneously, known as a cadaveric spasm, in situations such as trauma. And if there is temperature, high temperatures, like here in Miami, or exertion or exercise that preceded death, rigor will also be brought on much quicker. So the general timeline, normal circumstances, 2 to 4 hours, it can be recognized it's there. 6 to 12 hours, rigor is in its full-blown form. And after about 36 hours, a day and a half, you're looking at it having been completely passed. The chart underneath that is extremely important. Before rigor, you're going to have great absorption of your chemical. You're going to have very good firming if you're using a formaldehyde-based fluid. If you are in rigor, you're going to have little to type of absorption, okay? Firming is there, but you have to be careful because it's probably due to the rigor and not so much what you're doing. And then in the post-rigor environment, you have a tremendous need for preservative fluid. The protein centers have broken down. You have waste byproducts built. So you're going to have to be using a lot more to achieve a lot less. Firming is difficult to achieve, at least in as much it is more difficult than the pre-rigor condition. Decomposition is what breaks rigor. The body actually breaking down is what breaks the rigor. And in your stages of rigor, you have a primary flaccidity. Rigor develops, it's hardly noticeable. So that is the pre-rigor condition. It's starting to get on. You can barely feel it, just kind of there. Period of rigor, where you are basically bricked because of the rigor. And then secondary flaccidity. Rigor is past, and you are now in the post-rigor time period. Most problems are encountered when the body is in full-blown rigor. So it gives you the reasons why, okay? It gives you the reasons why in the different areas you have good to no preservative reaction, so to speak. So I would know this. I would know this cold if I were you. And it's not just enough to just throw out a couple of terms. You're probably going to want to know it's slightly alkaline, fluids work best in the range, the protein centers are still there. Then what ends up happening are engaged in maintaining state of rigor mortis. They're in the middle of actual cramping. That's what rigor mortis is a gigantic cramp. The vessel lumens, the holes within your arteries and veins are reduced, so distribution is problematic because it can't expand that well. You are in an acidic environment, which is not conducive to the fluids. And then finally, when you're down in the post-rigor, the actual things that your formalin was going to work on have broken down. They're broken down. The alkaline pH increases preservative absorption, but nitrogenous waste increase the need for preservative because you have the waste byproducts. It is imperative that in a post-rigor environment that you increase, you increase the amount of formalin being presented because it's going to need more of it to combat the ammonia buildup as well as the broken centers, the broken protein centers. Bodies embalmed prior to rigor just need to do your job like normal. Once broken, Borat tells you, rigor does not return. You're good. So problems with rigor. Features may be difficult, if not impossible, to set. The jaw is completely locked down. It is what it is. Because the muscles around that area, the throat might be impossible, and you can see all the other ones. And the big ones for you to worry about is that firmness of rigor can be a false sign of fixation. Okay? That would be a problem as well as the swelling. pH, pH of tissues in rigor is slightly acidic. We want slightly alkaline, slightly basic. pH will not be the same in various muscles, which also causes a problem. The increase of tissue pH in the alkaline range after rigor indicates muscle proteins have begun to break down or decompose, and now additional sites for reaction with preservative. So again, yeah, you might still have some protein centers, but because of the breakdown, there's more stuff that needs to be preserved. A body of bone while in rigor should be saturated so that it's available later when rigor passes. So rigor is breaking down, the ammonia byproducts are forming, and you have stuff there to actually prevent any issues. As the absorption of preservative results in firming, there is a relationship between the rate of preservative absorption by the tissues and the rate of firming. During rigor, the proteins are locked together. It's difficult for the preservative to attach. Most of the firming that occurs is because of the muscle itself, the rigor, the cramp. As well as the need for stronger solutions during rigor, you are going to need a co-injection chemical. And basically what it's telling you here is you need a buffer. You need to try to get that range where you need it, where it's going to work the best. So the buffers and arterial fluids help to achieve a uniform pH necessary for the preservative throughout the body. It's easily seen that distribution is not uniform. Dyes are not evenly distributed. Firming is not uniform, etc., etc., etc. So you cannot rely for firmness as a test of preservation with bodies in rigor. Firmness can result from swelling, from the cramp itself, but not from the injection. So what are some ways that you can set features in rigor? And it tells you the process to do it. Tells you how to adjust things, try to break the rigor gently so that you can get the body positioned for casketing. They recommend restricted cervical or multi-point. Restricted cervical or multi-point. Right internal jugular vein is the best drainage site. You're going to see that a lot in all the chapters. When in doubt, go right for the right internal jugular. Medium to strong arterial solution should be used. So you're looking at a 2% plus solution. 2% to maybe a 4% would be medium to strong. You're probably going to use an appropriate type of chemical. Probably 18 index plus, 18 index being medium index to anything over 25, which is high index. Definitely want to throw in some tracer fluid, some dye, so you can see where it goes. But be wary, because depending on the solution you're using, it may have an adequate number of dye in there. And as I have found playing with different manufacturers of chemicals and just using their chemical, I have found very few instances where I've actually needed to add a tracer because of the amount of dye already in there. Blood drainage is often minimal as well in bodies in rigor. Some embalmers start light, 1.25 to 1.5%. That is below what we need at the 2% minimum until the discoloration is clear. And then once the discoloration is gone, they will then re-inject the body with a higher 2% or better solution. Never, ever, ever use a pre-injection when you think you encounter swelling or any other distribution difficulties, because you don't want to put fluid in. This only purpose is to make your life miserable. Using a minimum amount of strong solution helps to control swelling and achieve good preservation. What I put in will be sufficient to do the job. So you get a refrigerated body, and I will tell you that here in Miami, using the morgues, on some days those morgues seem to be working overtime, and I have to let the body thaw, because if not, they're going to be frozen, which is problematic. So whenever they have gone anywhere, if you're not picking up right from the bed or the facility, they're probably going to have been in refrigeration, okay? And it's really hard to kind of earmark when there is a magic moment that refrigeration poses special problems for you. You kind of just walk into what you walk in. But there are some advantages, okay? There are definitely some advantages. First is that short-term refrigeration slows rigor, slows decomp, and maintains blood in a liquid state. For mortis, it can be very intense within short term, so we know it's not post-mortem stain and we can flush it. The disadvantages are pretty extensive. And there's a lot of stuff here. Some of the big ones are the cold fats at the bottom for false firming, easy rupture of capillaries, dehydration, especially if they've been uncovered underneath one of the blower fans. These are all issues you need to deal with. Post-mortem caloricity, and if you remember what that is the body's temperature after death. May increase rigor mortis and decomp. It's not unusual to find that little green area over the abdomen, which we're going to look at in the discolorations chapter coming up. Bacterial activity continue. So the bugs that are in you might not like the cold, but those which aren't killed by cold are going to continue to do what they do. So if they are in you, which they are, they're going to continue to do their job. First, while the body is warm in their ideal environment, business as usual, and then they're just going to slow down as the body cools. If you haven't raised the head, well, the blood is going to flow from the chest. Okay, if you look at the way your head is positioned, your chin is actually standing up straight in good posture. It's just a little bit behind probably where your heart would be. So when your entire head is dropped back behind your shoulders, all that blood from your chest and your heart is going to flow into your head because of gravitation. Some bleaching is possible, but fact of the matter is you don't want to get the head stained if you can prevent it. All you have to do to prevent it is get the head raised appropriately. Post-mortem stain, Tardieu spots can be lightened, but they are extravascular and they cannot be removed entirely. So you're going to be using some cosmetic. Wrapping and sheeting for a long period while in refrigeration may result in dehydration. Basically, dehydration goes from yellow to brown to black for everybody, no matter who you are. Discoloration is not removed. Dehydrated tissue discolorations cannot be removed by any sort of injection. You have to use cosmetic. You have to use wax. You may be able to do some minor tissue building to swell things out, but fact of the matter is you are going to have to be doing some serious treatment to hide that dehydration. With delayed bodies, swelling is always a concern. Pressures are all throughout the body. As gas builds up in the abdomen, pushes down in the aorta, which causes distribution and diffusion problems, below the belly button and the lower extremities. And that's why we try to add dyes as a tracer. Again, use your best judgment. If you're using fluids with a lot of dye already in it, you might not need extra. Just pay attention to what you do. Extra amount of fluid dye should also help combat formaldehyde gray, the reaction of the heme that has broken down out of the blood itself, drifted into the tissues, and now has resulted in post-mortem stain. Skin of refrigerated bodies have a slight pinkness due to the hemolysis, which is exactly what causes that formaldehyde gray when the formaldehyde reacts with those components now trapped inside the tissues. It refreshes your memory as to what is a false sign of preservation, the cold fat, the swelling, or even, okay? If the head has been raised, dehydration may be present. Of fluids, yeah, all the water in the tissues in the head are going to flow into the chest when the head is raised. It's why you want that happy medium where it is comfortable. That's why we use a head block, ideal for you. But if you overdo it and you push that up almost at a 90-degree angle, you're looking at some probably dehydration issues. And definitely probably want to break out the massage cream or mineral oil. Some people have recommended spraying with the humectant chemical. But realistically, if you're trying to do maybe a day or two storage, your best bet are probably the emollient creams, something that will stay on a bit longer, not basically evaporate as quick. Mild arterial may be required for injecting the head due to dehydration. Let the body tell you what to do. Again, you don't need to go in there with the fast firming, guns blazing. It's just saying you might need to put some in so that you do not overdo the issue. Be sure to use appropriate supplemental chemicals, and by that I mean humectants and co-injection solutions. Because of the different needs of different areas of the body, that's why we always talk about the multi-point or restricted cervical. Isolate the head so we can treat the body one way, the head the other. And by now, this should be written on so many places, it should need to be said. If restricted cervical is used, and if you're going to do multi-point, then you can pretty much aspirate the cavities because you're going to do everything separate anyways. If purge develops, aspirating before setting of features eliminates the need to reopen things, clean the mouth, and go crazy. So you can basically do a 4-point, the legs, the arms, the torso, and whatnot. You've isolated the head, and then before you do the head, pack everything up, set your features, and inject the head. So basically you're doing a head freeze. Very thorough with your aspiration as well as the cavity injection. And it is recommended that you go in and re-aspirate bodies that have delayed periods. If any gas escapes when the trocar button is removed, the cavity should also be re-injected after aspiration. Something is causing the gas. So if you have used, and I like to use the formaldehyde-free cavity chemicals. I'm a big fan of that stuff, especially when dealing with first-time embalmers in my labs. If that's the game and some gas is coming out and there's a definite odor, I'm probably going to pull out the big guns and go for some of the, really take no prisoners cavity formaldehyde-based chemical. So be sure to go back to, I think it's chapter 15, the cavity embalming chapter, and reread that if you need a refresher on what's going on with cavity embalming. As little water as possible should be run over the body during embalming and with the final washing. You may want to consider doing a clean embalming where you use a drain tube and a hose hooked up, then drop the end of the hose down the drain so nothing contaminates the body. Dry the body thoroughly. Use a hair dryer if you have to. Cosmetics should be delayed until tissues have time to warm because you don't want the cosmetic to have a bad reaction to condensation or something like that. Use some massage cream, use some tissue builder to help plump things out if you need to. And again, restorative art's going to cover a lot of that for you. There's also a restorative art subsection in this embalming book. Check those things out in your time. When a body is frozen, ice crystals form. Those ice crystals will then tear tissues if they disappear too rapidly. Okay? So you don't want to just run warm water over the body trying to loosen it up. Basically treat it like a piece of meat. The only thing you can do, bring it out to room temp and let it happen. So walk it into your embalming lab, let it sit there for 3 or 4 hours, keep your doors locked so no one walks in who shouldn't. Not that you should have an embalming area with open access to just anybody. Certainly not if you're going to give a family a tour of the place. And then once several hours have passed and the body's as close to, you can get, then proceed. Manipulation of tissues while they are frozen is going to tear stuff. So don't try to do too much massage. Don't try to break quote-unquote rigor because it's probably not rigor. It's frozen. Obviously, restricted cervical and multi-point is kind of a no-brainer here. So it gives you the guidelines for frozen tissues, little no drainage. Rate of flow should be very slow. And again, I'm saying that on most machines that's probably under 10. And then build into it. And notice the water should be warm to hot. So you should be using something warmer than room temp for the arterial solution. If you're using a specialty fluid, read the label. The label will tell you what to do. Most structures have a similar pink color of frozen tissues. So you should be using some dyes to kind of give you an idea of where things are at. After the passive rigor, noticeable signs of decomp can begin to be observed. Factors that speed up decomp, there they are. Environmental heat, retained body heat, high moisture content, water is a necessary item for decomp, and translocation of the critters already inside of your intestines. So the first external sign of decomposition is the green coloration in the inguinal iliac version or area of your abdomen. So the bottom right, it's right over where basically your large intestine is. Eventually, as time expands, it'll marbleize, the outline of the intestine will show, and it works its way then up and down. It can go as high into the head, and obviously the body can then be marbleized and disgusting. You see marbling going on here. That's that spider webbing effect that goes on, and that's because it combines with hydrogen sulfide to form this discoloration within the vasculature that rapidly then becomes an extravascular problem, and it's not going to go away. That is a cosmetic and bleaching treatment solution. Liver mortis and stain, we're going to beat this up a lot, so I'm not going to really bash on it again. It does bear mentioning that Tardieu spots, or capillary breakdown and cause petechial and purpura, it's a Tardieu spot. Realistically, that means petechiae in a bruise. So if you look right down here, you see that small bruise, you see that little red dot in the middle, that would be an example of a Tardieu spot. But generally, Tardieu spots are much larger. We've also talked about dehydration a lot. We'll be talking about dehydration again in another chapter, moisture considerations. For the most part, you might find dehydration in fingertips, nose, lips, and in the male scrotum. Odors, obviously, as you rot, you stink, and it tells you why. Embalming converts almost all of these to an odorless methylol compound. So the things you saw there, the mercaptans and amines, formaldehyde's going to get with that, and it's going to help offset it. It converts ammonia to odorless hexamethylene, but the problem is formaldehyde really likes ammonia. So ammonia really takes a toll. Make sure you're putting enough formaldehyde to make stuff happen. It also says that you can perform this little mixture right here. You're not going to run down to Bath and Body Works to find it. Mix 2 pints of hydrogen peroxide with a ½ cup of baking soda and then some liquid soap. Leave it on the skin for several minutes, drying it out. I have not tried that. I might do it at one of these labs just to see what happens. See perfringens, that's your buddy that causes true tissue gas. It's also a causative agent in gas gangrene, and it smells like hell, and we've talked about it ad nauseum throughout this course. Purges, I'm not going to talk about purge because we talked about purge in the previous chapter. It tells you basically nutshelling gas formation. If it's hot and basically humid, gases form quick. If it's cold and dry, gases not so much. Gases cause swelling, which result in severe disfigurement, which result in purge. Remember, you need an object to purge, a pressure that does it, and a hole for it to come out. Skin slip, I'm not going to go into detail, but skin slip is basically a problem, especially with decomp. It's one of the cardinal signs of decomp. Within chemical changes, it says autolytic and proteolytic decomposition of the body proteins results in tons of ammonia byproducts, nitrogenous waste, nitrogenous products. This increases the demand of the body because there's more stuff to preserve now. And their presence shifts the body pH back to alkaline. So it was slightly alkaline, went acidic during rigor, and now it's coming back to alkaline. Embalming protocol, well, this is vanilla embalming 101, which we should basically know pretty good by now. So, when encountering the delayed injection, maximum strength fluid should be used. So we're looking at probably nothing less than 18 index. And I'd probably say that you're probably wanting to shoot for the 25s or better. That's just my knee-jerk reaction. Supplemental chemicals as needed, but don't do that to sacrifice solution. So I would not add in a bottle of Edemaco and take away a bottle of another solution of some type of preservative just because I added an edema corrective trying to dry things out. Preservative is important. Supplements help your preservative, so never sacrifice your preservative for a supplement. Pre-injection is done. Don't even talk about it. Dyes as a tracer is a gimme. If you haven't figured out by now, restricted cervical, multi-point injection. Purpose in the 6th point is to reduce the number of clots that move into the smaller arteries. So by going into these areas directly, we do not run the risk of clotting things up like we would starting with a 1 point somewhere else. The aorta's probably got tons of coagulant in there, and pushing any of those big chunks down an artery into a smaller branch is just going to block it. So it says start in the legs, go to the arms, go to the trunk, using the carotids, and at all times leave the head open. So you've opened up your left and right common carotid, and you're just letting it kind of happen. Aspirate right after injection, okay? Set features, left side of head, right side of head. Aspirate cavities again, eject with an appropriate cavity fluid, which generally means for us practitioners, none of the formaldehyde-free stuff. Use the real deal, okay? Supplemental treatments as required. Cotton compresses, cavity compresses, hypodermic injection, etc. When the book talks about restricted cervical, you're going to see that it sounds a lot more like multi-point injection. The big thing to take away is you understand head is injected after everything else is done. Okay? And then after the head is injected, you re-aspirate and re-inject. If you do have some swelling in the guts, remember, you can keep the trocar towards the anterior top portion of the abdomen so it doesn't pierce the aorta, and get it in to help relieve some gas. We've seen that in previous chapters. And slow rate of flow. Slow rate of flow and build into it. Sometimes you are best served, honestly, just waiting the body out. Just wait it out, and in most cases, you'll actually be surprised. Limbs should be injected slowly. Increase it once you've established distribution. For blowing a clot and blocking something you don't. Pulsation is a gimme. You can even do instant tissue fixation on limbs. Don't think it's just, quote unquote, a head freeze. You can use it anywhere you need to push very concentrated fluid into an area as quickly as possible. And generally when you're doing that, it's a waterless solution. And remember, waterless does not mean just arterial preservative. It is arterial preservative only co-injection and supplemental chemicals, no tap water. Take note of the injection points for hypodermic injection using a HYPA valve. These would be very important. Know those. Reaspiration, treat skin slip as necessary. Embalming powder, plastic garments are also a gimme. You should be using this stuff on delayed bodies because you might not know how things are going to take. Dehydration is never a concern in a decomposed body. If a body's decomposing, it has more water than it knows what to do with. So you nuking it and draining it is fairly important. Mouth can be closed after arterial injection for reasons stated earlier, cleaning of purge, swelling of whatever you might need to. And it also may be easier to close after injection due to swelling. You know, if the body's going to swell, it'll actually push the jaw up for you. Take what you can get. Be prepared to use compressors for preservation on face. Lips can be secured with an adhesive. You know, use your best judgment when dealing with bodies severely decomposed. Eyes can be closed, so go back, look at some of those chapters that deal with eye nucleation. Look in your restorative art book for ways to close and deal with eye swelling. Adhesive is probably a good idea, but be careful not to get any in the lashes. And it talks extensively about swelling, again. So as you can see, swelling is an important thing that we have to address. In the event of a tongue problem, push it back, then try to down with needle and thread, or realistically, if you're having a tongue protruding problem, barb injector is probably not your best solution for that. Needle and thread, a good start. Might even need to do one of those other drill and wire, more extensively problematic solutions that we wouldn't consider doing. And last but not least, we simply start chopping things off. Again, that is the method of last resort. You do not just walk in and chop out a tongue because it is quick and easy and convenient. Have a reason to do something like that. This is someone's loved one. Even if the body is completely, quote-unquote, unviewable. J. Sheridan Mayer's book does not advocate anything regarding a non-viewable body. Any body can be made to be, quote-unquote, viewable, according to the scope of the book when I went to mortuary school. Dr. Clicker, in his book, actually has a chapter on the unviewable case. And many of us modern practitioners would probably say there is a point in time where it becomes a quote-unquote unviewable case. And even in that condition, we should do something. And it says, basically, you're going to nuke the body. You're going to get the highest, fastest firming fluid that you have, and you're just going to shoot it full of whatever you possibly can. Just to try to preserve what you can, reduce some of the odors, which you know probably won't dramatically be reduced. But at least you've done something, and then follow the protocols within Dr. Clicker's restorative art book on sealing it properly so odors do not leak, and then proceed with funeralization. You are most certainly going to aspirate and inject multiple times on something like this. If it's an unautopsied body, you're going to have to go and get that hypovalve trocar and inject the abdomen as if it were flaps. You're going to want to make sure you get some of that surface tissue preserved. The primary purpose of doing this is simply to reduce as much of the odors as possible because you don't want people offended sitting in your chapel. After you're done, covered in autopsy gel and embalming powders, sheeting to wrap the body should be saturated in cavity fluid. So it probably doesn't need to be mentioned, but I'm going to mention it anyways. You probably want to be doing this with your ventilation systems on full because this is going to be extremely irritating to the practitioner. Body's then wrapped in sheets and placed in a clean pouch. Don't dilute any chemicals used. Just kind of do it. Put more stuff inside there, including some kitty litter to help soak things up and reduce some odors. Surface glue the zipper, so you probably want to grab some, rubber cement or something and kind of suture all that up with your cement so that nothing leaks out and stinks. If you look at Dr. Clicker's restorative art book, he explains a process for doing this very effectively, very well, and it does make use of the second pouch. So I highly encourage you that if that is not the textbook that you are using at your institution, or that's not one that you have right now, there is an excellent chapter on how to do the non-viewable case in that book, and it will be worth it from a personal standpoint at the funeral home for liability. When moving the pouch, you probably want to put it on sheets and kind of move it around with that so you don't run the risk of pulling something out. And I'm going to also clarify, when we talk about disaster pouches, we mean this thing right here. Okay, we're not talking about the hospital level body bag. That is not a pouch. That is not going to be sufficient for what we're talking about here. We're going to definitely want this to be a disaster pouch. And understand, I'm not advocating you should be charging some of these expenses to the family, because it's a kind of a accepted thing that if you're using a disaster pouch, if you're going to do that, you might want to put it on your general price list in the event that happens. And if this is going to be your standard protocol for embalming someone like this, you might want to consider those costs when putting together your embalming costs, being mindful of the regulations that we are put on regarding ancillary charges through the Federal Trade Commission when we're talking about pricing. So it is 10 in Restorative Art by Ralph Clicker, PhD. And I've been beating that to death. So again, folks, thank you for your patience. Hope you found this informative, and we will see you next time.